Good to see everybody there here this morning, and wonderful to start a brand new academic year. And I seeing a lot of the new names of our new fellows, and as we go through our time together on these Thursday mornings, hopefully we'll have opportunities to get to know each other better, and we'll look forward to that. Speaking of which, if you look at the schedule, we will not be having a case presentation today, and I think next week. We like to give the fellows a time to just settle into the routine and actually see patients that will be able to represent interesting things to share with the group. So it's great to see you all here, and I'm just hang on just a second here. Okay, got a little glow on behind me there that I'm not sure how to get rid of, but no matter. We'll be looking at slides primarily today. So we typically have historically like to start our lecture years with pain, and there's a reason for that. It is the most common symptom that you as HPM fellows will be called upon to address and to treat. And because of that, then we've got a handful of lectures on pain in general, as well as some specific ones coming up: methadone and buprenorphine and interventional things of that sort. But I like to kind of just get started by talking a little bit about kind of philosophy of pain, if you will, as we begin to understand why we treat pain, and some of the nuances behind why pain is such an important topic for us to really have ingrained in our soul. I like to start out by just acknowledging, and I hope you understand this, that every single day in our hospital systems and offices across the country, people are suffering. And it's been one of my passions for a long, long time to try to deal with, address, and eliminate preventable suffering. And a lot of times people are suffering because of attitudinal and philosophical issues, and not because we don't know how. I also want to make sure that we understand that as physicians, although the easiest thing is always to pull the script pad out of our pocket, that sometimes that's not going to be the most effective way of managing someone's pain. So we look at pain as a totality of the person that is affected by this, or as Dame Cicely Saunders, and the fellows, you need to understand that's a huge name in our field. That Dame Cicely Saunders was a physician in Great Britain who started St. Christopher's Hospice, which is generally considered to be one of the most, probably the first contemporary hospice house in the United States, and I'm sorry, in the world. There have been other ways that people have addressed end-of-life care, but she defined this concept of total pain that really captures the essence of not only physiological but psychological and spiritual dimensions as well. So we're going to talk about some of that today. So let me bring my slides up here, and we'll get going on this here. There we go. Okay. So just a few quotes to start with. Again, this is Isaac Singer. Death, I understand very well. It is suffering that I cannot understand. I got to tell you, I sort of agree with him. It just perplexes me why many physicians will not extend beyond the little box in which they practice and look at creative and meaningful ways of treating someone's pain. And so one of the things that hopefully you pick up during the course of your fellowship are the wonderful and unique ways that we can address pain and how we think about it. because that's going to make a difference at the end of the day in terms of how we treat it. Ed Pellegrino was a ethicist who said not to relieve pain optimally is tantamount to moral and legal malpractice. And there actually have been a few cases, mostly on the West Coast, in which the plaintiff sued the physician or institution because they or their loved one was allowed to suffer. Most of those were prosecuted under elder abuse statutes, but it's a big deal, and it's becoming a bigger deal. Now I have to juxtapose that to the issues of the opioid crisis, which most of us are faced with and had some that has cast a negative pall over the work that we do and made people a little skittish or reluctant to prescribe opioids. And we'll talk about that along the way as well. And from Andy Warhol, I always like this one. It's not being dead that I'm afraid of, it's getting there. We, in the medical field, have made people concerned and suspicious as they've approached the end of life, and they have suffered. Their family sees it, their friends see it, people in the hospital see it, how horrible it can be to have particular diseases because of how people suffer. And that yields this philosophy that, the dying is horrible, and, or as I think Woody Allen said it's not being dead afraid of it. It's I just don't want to be there when it happens. And so we need to be very diligent to make sure that when folks are interacting with our patients, they are able to see sometimes the wonder and the opportunities that exist for us at the end of life. So if we're going to talk about pain, we need a good definition. Margot McCaffrey is a nurse considered to be one of the gurus of pain here in the United States, had this quote, which is generally accepted to be one of the better and more concise quotes we have about pain. It is whatever the experiencing person says it is, existing whenever he or she says it does. I, as a patient, get to determine what I think is pain for me, and so do all of our patients. There are varying degrees of comfortability that physicians have with that philosophy. We're trained in a scientific method that says there has to be a identifiable way of identifying anything that we treat, diseases, and so we get lab values, we get X-rays, and we love the black and white, the definitive aspect of that allows us to say, yep, that's it, or no, it's not. Pain doesn't work that way, and we have to acknowledge that because there's so many different dimensions of pain. I've told people, yep, I raised 8 teenagers. I understand what pain is. I've had major surgery, and I understand what that type of pain is too. I've broken bones. I understand what that kind of pain is. Grew up with 3 sisters. I understand what pain is. I actually love my sisters, so you don't need to tell them that one. But so our patients get to decide what they're going to, how they're going to identify pain in their lives. Our job is to ferret out what does that really mean for them, because that's going to help us do that. Now, thanks again to Dr. Alice Emery for the graphic on this one. I just like what this portrays. You cut your finger, and then there is a pathway that ultimately allows us to interpret that as pain. Starts in the periphery of that nociceptive stimulus, and it travels to the spinal cord. There's a synaptic transmission in the dorsal root ganglion, travels up to the brainstem and the thalamic nuclei, and from there the corticosensory areas. So this ramifies more widely in the cortex as it is given meaning. And I bolded that bullet, and we're going to talk a little bit about that, because that's a huge deal as we try to understand the meaning of pain to our patients. Also, in that every step along the way, that signal can be up or down regulated, magnified, attenuated. and that there are opioid receptors throughout the pathways, mu, kappa, delta. We're more concerned about the mu's because that's where most of the work has been done, but within your career, I'm certain that there will be more drugs that come out that will be more specifically targeted toward the mu or the kappa. But let's talk about that bolded thing. How we interpret that stimulus in the brainstem plays a large role in understanding what the pain is and means. And I want to give you just 3 quick examples. One is one that many of you have seen. In the hospital, you've been at the bedside of a patient who's in pain. They ask for their pain med. The nurse dutifully comes in, cleans off the little stop thing in the tubing, and inserts the needle and begins to slowly infuse the Dilaudid or morphine or whatever the opioid of choice is. And if you look at the patient's face, you can just see it just easing almost immediately. It's less tense, it's more relaxed. They might sigh a little bit, very appreciative and thankful. The interesting thing about that scenario is that in many cases, the drug hasn't even left the tubing yet, let alone had time to get into the bloodstream and hit some of those mu receptors to actually relieve pain. So how can that really be? Well, it's real, that's for sure. It's not like it's a fake thing, but we have our endogenous opioid system, the endorphins, that will kick in. And if we anticipate and we know that pain is going to be relieved, they're pretty eager, and they get out there in the into the system and hit those receptors and start causing pain relief immediately. And it's not until probably 10, 12, maybe 15 minutes later that that drug actually hits those receptors, and they tell the endorphins, "Thank you for holding my spot. I'll take it from here." So that's all a central nervous system thing. Because we anticipate pain relief, our body may indeed begin to experience it. A lot of you have probably seen people who had pain we weren't sure what it was. As soon as we identified the origin of the pain, then all of a sudden our pain seems to be better because we have a better sense on that. I had a situation, it was probably 35 years ago, maybe longer, in which I was cutting down some trees. I wasn't cutting them down, they were already cut down, but I was kind of chopping them down and to size and for our wood burning fireplace. And I'm not that adept with power tools and equipment and things of that sort, but I had a chainsaw that a friend had lent me, and I was kind of cutting down these logs. And in one particular circumstance, I had my left foot braced on the log, and the chainsaw hit a knot and it bucked, and I kind of went back. And as I came back forward again, the saw came down across my left foot. I had a tennis shoe on, and in this very slow motion instant, I saw my shoe shredding. I saw the white tube sock I had on, fibers of this white thing shredding also. And in that instant, I realized, oh my gosh, I cut my foot off. And I had this searing pain, and it just was horrific. And I could feel myself sweating and palpitating and a little dizzy. And I, tossed the saw down and dragged my foot into the garage and sat down on the stoop as I very gingerly took off what was left of the shoe, and it was cut all the way down to the sole of the shoe. And this and the shredded sock. And as I peeled those off, I realized, I thought there would have been more blood, but as I finally peeled the sock off, I realized I had a fully intact foot. Now, whether this was a situation of, in that instant when the saw came down, my brain realized it and retracted the foot so that it wouldn't be harmed, I really don't know. All I know is when I put the sock and shoe later back on, I could see that the cut went right across the metatarsophalangeal joint. The thing is that as soon as I saw that it wasn't cut off, the pain completely went away. So my cerebral cortex was very, very vivid in recognizing, yep, you cut your foot off, it's going to hurt. Nope, you didn't cut your foot off, so it doesn't hurt anymore. So I've always thought about that when I understand the patients are complaining of pain. What is the cortical impact of that? The third I want to tell you about is my uncle. My uncle Bob, long since deceased, had encephalitis when he was a child, 2 years old, and that left him profoundly developmentally delayed, and he lived his whole life relatively healthy, but with significant impairments. And one of his impairments, because of the area of the brain that was affected by the encephalitis, was that he could not feel pain. That yielded some medical issues along the way. He had at one point developed a toxic megacolon because he did not have any sensation of abdominal pain, and that caused some issues for him. One night I got a call, I was his power of attorney, and that he was in the ER, had been hit by a car. He was a voracious walker and walked 10 miles a day, and when he was out walking, a car jumped the curb, hit him, and drove off. He had bilateral open femoral fractures and had bilateral hemopneumothoraces, and he had a depressed skull fracture. The fact that he survived it all was really kind of a miracle. But the doc called and says, it's just really strange. He said, he's lying there on the table talking to us like nothing happened. We were able to set his fractures and also to put bilateral chest tubes in. And he didn't seem, no anesthesia, no analgesia. He just is sitting there talking to us. And I said, well, that's Uncle Bob. Yeah, he doesn't feel pain. So his cerebral cortex was impacted by that. So I just want you to remember that the cerebral cortex has a very, very significant role in patients' interpretation and expression of pain. So what's the intention? Why do we treat pain in the first place? Well, three main things. We want to decrease the level of perceived pain, and that word perceived is there intentionally. Because if someone like my Uncle Bob is not feeling pain, do we have an obligation to treat it, even though if we suspect and know that the stimulus is likely to cause pain? If they're not perceiving pain, then do we really have a need to be aggressive with it? We want to improve functionality, and I'll be talking about that more through the course of this morning, because that to me is a huge deal. How does the pain actually impact your function? And finally, we want to improve mood. We know that there's an integral link between pain, anxiety, and depression, and which came first is sometimes questionable, because they might be depressed because of the chronic pain, or they might have a lowered pain threshold because of their depression. So we need to make sure that we're addressing those as well. So I want you to think just through a simple algorithm. When someone is complaining of pain, what's going on? We sort of split it into 6 main categories. Nociceptive pain, and that's kind of the garden variety, generalized approach to pain that says, I hurt this area of my body and that hurts now. Or I have this disease in this particular organ and that is bothering me now. I have metastases to the bone and the bones hurt. So in most every circumstances, both the team, the physician, the patient, the family, they get it. They understand why the patient hurts, and they would say, yep, that's legitimate pain. And again, we as practitioners have a great capacity for placing judgment on our patients, whether we know it or not, whether we're conscious of that or not. We do, in terms of our being able to align our expectation of how much pain they should have with what the actual underlying disease is. And so one of the things I want to make sure that we're conscious of as we negotiate, not just your year of fellowship, but your entire practice, is to make sure that we're keeping our own perceptions on how we would react to something on the sidelines. Doesn't mean that doesn't matter, but we need to be careful about judgment. Neuropathic pain, and we'll be talking more specifically about that later, in which there's actually dysfunction of the nerve, and and that's a specific issue in and of itself, of course. There is central pain, or sometimes known as central neuropathic pain syndrome. And this is where there's been some element of injury, damage, or pathology in the central nervous system that is contributing to pain. And this is where some of the more difficult pain issues fall. Fibromyalgia, chronic pain syndrome. But you can see people that have had strokes, that have had cord injuries. Sometimes it's not that dramatic. I've had two young men with central neuropathic pain from brain injury, one from cerebral radiation from a metastatic testicular cancer, and another that had chronic pain from a cord injury that was really quite dramatic, and to this day is one of the more challenging pain situations that I've had to deal with. So it almost always is described as generalized. It's not a focal one spot where it hurts. It hurts everywhere. And a lot of times when we see patients who complain of pain everywhere, we have a greater sense of thinking that, oh, it's not real, or they're malingerers. But we need to be conscious of a central pain syndrome because it is hard to treat. But if we just dismiss them, then we're doing them a great disservice. So we want to think about that. When someone's talking about pain all over, and especially if they have these allodynias and hyperesthesias, those are all hallmarks of central pain. Of course, there's psychospiritual pain. And we talked about that just briefly a moment ago: depression, anxiety, spiritual struggles that people might have that could be contributing to why they're feeling the pain. Under spiritual struggles, I'm not going to spend too much time talking about the concept of meritorious pain, in which people, it's part of their spiritual journey, hurting is, just having the pain that Christ felt, for example, or as I deserve this because I'm such a bad person. So psychospiritual is huge, and we need to make sure that we're understanding and respecting the fact that that could be affecting someone's pain experience as well. Aberrant behaviors. This is probably an area where physicians get the most nervous because as physicians, we don't want to be responsible for putting more drugs out into the community that patients are either selling, diverting, et cetera. We also, a secondary gain. I've seen patients for whom the medical care system, it's their social life. It is their point of connection with caring human beings. And they may not have diseases that would warrant intervention, but they can complain of pain. And that will be something that gets them into the door and face to face with someone that cares for them and cares about them. So we need to be aware that those types of behaviors are a reason that someone may come into the office complaining of pain. And addiction, which is again a psychological disease, substance use disorder, we're going to have a couple of lectures specifically relating to that later in the year. So we'll get there. So we're not going to talk too much about specific addiction or substance use disorder today. So this slide is just something that should be second nature to all of you. I'm just taking a moment to talk about it because if we don't effectively evaluate the patient, then we're never going to be able to work through those 6 different categories of pain and figure out what is causing their pain. And it's not just us. As serving as a hospice doc for many years, it's not unusual. I would get a call from a nurse. Hey, I'm out to see Mr. Smith, and his pain was a 4. It's now a 7. What do you want to do? My question will always be to them, well, tell me about the pain. What's his underlying diagnosis? And where is it? Can we figure out why the patient has pain? And often the nurses themselves have not done enough deep dive to be able to tell me what's going on. And it's hugely important because it may impact what we're going to do in terms of pain. So just really briefly, focal or generalized, onset and course, exacerbating leading factors, previous treatment. I'm a big believer that we need to listen to the patient and for them, what has worked and what hasn't worked. Um, we always, and it's in our start talking forums as well now, are pretty big about making sure that patients don't take others' meds and we don't share our drugs with others and that sort of thing. But sometimes I will ask someone a question such as, it's not unusual when people have this type of pain to be pretty desperate sometimes to get relief, and they're offered something from a friend or a caring relative who has had pain, and so they might offer you one of their pain pills. Has that ever happened to you? And if so, how did it work? And I try to get an answer from them, and I would say most of the time people say no. It says, well, yeah, you know what, my next door neighbor had back pain and had this drug called Percocet left over, and he gave me one. And I said, and did it work? Yeah, it really was pretty effective. So at that point, then I will remind them that that's a bad practice, that within the context of our relationship, they should not take anybody else's meds, but talk to me, talk to our team before you take that, so that we can make sure we have you on the right regimen. I don't chastise them or berate them. I just make sure they understand not a safe practice. But if it helped, I'd like to know that, because that's a nice opportunity to begin constructing a pain plan for them. Previous diagnostics it might have done, associated symptoms, because those are big too. Sometimes you can treat 2 symptoms for the price of 1 drug. So it's important to know what all is going on in terms of the diagnosis and other symptoms they may have. Again, functional impairments. I got one more slide that I'm going to talk about that a little bit, so I'll get back to that in a moment. What's their support system? Who do they live in the home with, and what is their histories? Do they have people that are within the HPM field? In general, our patients have serious disease, advanced disease, life-limiting diseases, life-defining diseases that have impact on family as well. So who do they have within their world that's helping them to manage life with this pain? Psychopathology, it's important to take that history too. Have they had histories of anxiety, depression, bipolar, things of that sort? And I put family history of pain syndromes. We learn a lot within our family system. And if you've grown up within a family that has a tendency to very quickly reach toward the medicine cabinet anytime there is an issue, then that becomes a comfortable and a known pattern of behavior that you may adopt as well. So it's important for us to understand that. Are the patients opioid tolerant or naive? This is particularly important with someone coming into the hospital. I've had folks come into the hospital and had their regimen completely changed up because the physician didn't feel comfortable with that particular type of a regimen. And we've also had circumstances in which someone's coming in for surgery, for example. They've been on a particular dose of an opioid. They have their surgery, but they're not placed on that back post-operatively. Or they're given too little, or they're given too much. So we need to understand what their baseline opioid exposure is, and that you want that for all of your patients all the time. And if someone is coming into the hospital, we want to have a good sense as to what is the pain regimen before they came in, and how we're going to address that as they go through the course of their illness. So let's go back and look at these a little more detail about these 6 different subdivisions of pain that I identified earlier on. Again, nociceptive or garden variety thing. Anything with an itis after it probably fits into this. An inflammatory response, for example. Visceral distension, trauma, post-op. I would expect people to hurt after surgery, after you've been cutting into them. Muscle, ligament strain, sprain, things of that sort. So again, those are the kind of the garden variety. It typically is localized to the area of pathology, and usually the sensory exam is going to be normal. And the pain is in the appropriate spot. It's where you would expect that it would, given their underlying disease or pathology or injury. And so the therapeutic response, well, first you try to correct the underlying problem. And if it's severe, you might want to consider regional anesthesia. Depending upon the type of inflammatory disease, you may want to consider steroids. We're talking more about that when we talk about adjuvant therapies. NSAIDs, acetaminophen, should be the first line. We might consider opioid depending upon the severity of that. Neuropathic pain. As I mentioned, neuropathies occur when there is actual damage to the nerve itself from a number of different sources. Peripheral neuropathy is probably the most common type of neuropathy. We see that frequently in the diabetic population. And in these days, we're seeing more and more as our cancer treatments become more sophisticated and more effective. We're seeing people live longer with their cancer, and so we're seeing more peripheral neuropathies evolve. And then there's complex regional pain syndrome, which it acts like a central pain syndrome because it's a regional pain. And it involves some other aspects of the nervous system. Polyneuropathies, radiculopathies, phantom pain. It's always important on the phantom pain to understand how real that is. I've had physicians who have poo-pooed the idea. I've cut the leg off. There's no way it should be hurting. Not understanding the pathophysiology of phantom pain. But you treat them as any other neuropathic pain, whether they have a body part there or not. And the other thing is, it's not just a limb or a digit or something like that. Post-mastectomy pain syndrome is a very, very real pain, and it's a type of phantom pain. Anytime we lose a part of the body that has the capacity and potential of hurting, we need to keep that in mind. Scars, burn pain. Burn pain is considered by some to be one of the most severe types of pain that we can have, and so that's particularly important to recognize. Something like zoster, postherpetic neuralgia, is another type of neuropathic pain. Trigeminal neuralgia, or tic douloureux, pathology of the trigeminal nerve, which can be very, very severe. I remember many years ago watching a doctor TV show when I was a kid. I mean, this is how long ago it was, and the whoever was experiencing the pain was so severe that they took and they put their head into an ice machine that it was a big vat of ice, and just threw their head into that to try to relieve the pain. It was so severe. I've never forgotten that image. I don't even know what doc show it was on, but chronic pancreatitis and other irritable bowel syndrome and other sorts of chronic abdominal pain is thought to be neuropathic in nature. And I think that's really huge to understand, because a lot of times when someone has abdominal pain and we can't identify the pathology, we presume it's functional or factitious. And I think we need to understand that this could very well be a treatable type of a pain used by using our neuropathic types of interventions. It typically, again, is localized to the area of pathology. Sensory exam is normal usually, but you want to do your test, your temperature, sensation, pinprick, vibratory, things of that sort. There can be loss of sensation, some allodynia, some paresthesias, and that really indicates abnormal neuron activity. And again, we want to search for correctable cause. Is it diabetic? Is it multiple myeloma, B12, alcoholism, trauma? Are just some types of underlying conditions that can give you neuropathic pain. I want to just pause a moment, because in mentioning multiple myeloma, people say, well, wait, that doesn't make as much sense. But we need to understand that our bones are packed with neurons, and you can take an older person, for example, that has some osteoporosis and has multiple compression fractures of the vertebral bodies, and they will describe it as though someone's throwing an ice pick through their back. The sharp, stabbing. We all know the adjectives that people use: sharp, stabbing, burning, pain. And so you can have neuropathic pain without having a classic lancinating pain down a dermatome. We tend not to miss those, the herpetic neuralgias. We don't miss those because they're so distinct and so obvious. But anywhere there's nerves in the body, we can have damage and we can have neuropathic pain. So it doesn't have to shoot anywhere or spread anywhere to be neuropathic pain. We're going to be listening to, and doing the history, listening to the description of the pain that would lead us to suspect that neuropathy is probable. There are a number of things that have been historically used, and what we use now, certainly tricyclic antidepressants, were what we relied upon for many, many years. Anti-epileptic drugs, when gabapentin came on the market, we now had another option and opportunity to treat pain. The SNRIs, local anesthetics, and compounded drugs can all be used to manage neuropathic pain. Neuromodulation, TENS units, for example, spinal cord stimulators, those types of things that interrupt the signal can be very, very effective for neuropathic pain. Injections, pulse, radiofrequency ablation of peripheral nerve, all these things can be used, sympathetic blockade. We say avoid opioids if possible. It's not that you can't use them in neuropathic pain, but the studies would really suggest that they are much less effective than our targeted neuropathic therapies. In my practice, I typically had used opioids as the adjuvant. Sometimes it's the other way. We start people on opioids for a specific pain type thing, and then might add a neuropathic adjuvant. But in the case where we have clearly identifiable neuropathic pain, the opioids may be a second or third line option for you. Mentioned the difficulty in managing central pain. I was curious. I went back to my Harrison's internal medicine book that I picked up in med school, and I realized that it's been well over 40 years since I graduated from medical school. But I was just curious what they had to say, decades ago on that. There was one paragraph in the entire book that was dedicated to central pain, and the basic sense of it was, we're really not sure why they have it, and there's really no effective treatment. So put them in a dark room and sedate them. And it was a little humbling to know that I, learned my medicine in a somewhat arcane world, but that's what they said. So I'd mentioned central nervous system injury, so a stroke, traumatic brain injury, chronic pain syndrome, fibromyalgia, somatization. All of these are very real and they are treatable. Multiple sclerosis, and I would probably extend that to say there are a lot of progressive neurologic diseases that we sort of minimize the capacity for them having pain. I had the opportunity to work in an ALS clinic for a bit of time, and when you read the older literature on ALS, they sort of minimize the possibility that they would have pain because it's a motor neuron disease. But how the body functions and how the body responds to the progressive disease can in fact yield some very specific neuropathic pain. So don't minimize someone's complaint of pain just because your history and what you have learned to this point doesn't suggest that they should have pain. They may very well have a very significant neuropathy related to their progressive neurologic disease. I mentioned the spinal cord injury, and opioid-induced hyperalgesia is a neuropathic pain. And one of the more challenging cases that I had mentioned was a young man who had been in a diving accident and had a lower cervical spinal cord injury. And he was paraplegic, had minimal use of his hands, and he was able to breathe on his own. But presented to his local hospital a couple of years before I saw him, 2 years after his injury, with this severe pain from the mid-chest down. They tried him on initially opioids, and they advanced the opioids. It didn't work. But that's all they ever put him on. They just kept dialing it up, dialing him up. And when he showed up at the doorstep of our facility, he not only had the significant central pain, but he was hyperalgesic as well. And his pain syndrome required a fairly dramatic and aggressive approach. We ultimately put him in the ICU, sedated with propofol, started some TPN, and had him on very, very high dose ketamine for about 3 or 4 days, and he woke up pain-free. The challenging part for him was that he did not tolerate the ketamine when he was awake. It caused very severe psychomimetic side effects. So he had to look for other strategies. But it was just an example of how the treating team at a small community hospital did not do him any favors by simply increasing the opioids and now making him hyperalgesic. So central pain, it can be a challenge. It can be a real challenge. As I mentioned, it's non-localized or localized to the area of the CNS insult. Sensory exam is going to be abnormal. They will have hyperalgesics and paresthesias. Allodynia is almost always present. So again, you test your pinpricks and vibratory sensation and things of that sort. Search for a correctable cause, quite frankly, which you may not find. There may be some psychosocial factors that are contributing to it, and they might have hyperalgesia, which you can in fact treat, but it's going to be difficult sometimes to find the underlying cause for central pain. We approach that very similar to how we do the neuropathic pain. Tricyclics, anti-epileptic drugs, SNRIs, sometimes antipsychotics can be of value. Psychotherapy, can you teach someone how to manage pain? Yep, absolutely. We'll talk more about that in later days, but not this morning. There are some articles out talking about deep brain stimulation as effective. Even I've read a couple of articles about ECT, or shock therapy, to treat central pain syndrome, and also again avoid opioids. Psychospiritual pain is a big deal. The pain may be vague, non-localized. It may be resurrection of a previous pain or exaggeration of minor insults. It's important to take a spiritual history here. We want to evaluate for depression, anxiety, other psychopathology. Again, consider meritorious or redemptive suffering. It's really critical in these situations to have your hospice social worker, an outside psychologist, chaplain, other spiritual advisors. Can be very, very helpful. Analgesics are adjuncts only and are related to the pathology. That's really important. I sometimes will ask students when I have them, can I treat the pain of a broken heart with opioids? And their initial response is they shake their head no. And I said, well, actually I can, and they will feel better. But clearly it's not the appropriate way to treat that. One of my former patients in my family medicine days, years and years ago, had come into my office and was sitting at the chair in the corner of the room, and she was slumped over, head down. I walked in the room and she says, oh, Dr. Mulder, my head hurts. My back hurts. My heart hurts. She made the connection for me. I didn't have to, try to convince her that somehow all of these were related. I had a young teenager that was quite aberrant in his behavior, causing them fits. Marriage was on the rocks, work not going well. And she attributed her back pain and her headache to all of the challenges that were presenting in her life. And so we could deal with those in different ways other than just simply giving her some Norco and seeing her back in a month. So it's really, really important to understand the psychospiritual impact of that. Aberrant behaviors, addiction, as I mentioned, we've got a couple lectures coming up later in our series specific to this. But just a few things. You want to get a thorough history of previous medications, the medication taken in the past few days. MAPS, you're required to be checking that, especially on your palliative patients. when you're changing drugs, changing doses, things of that sort. Urine drug screens are useful for identifying, is the patient taking what we're giving them? It's not, they're not qualitative, they're just I'm sorry, not quantitative, they're just qualitative, it tells you if they're taking that or not. More importantly, are they taking something else that you don't know about? What do the records in the patient indicate about a history of drug or alcohol misuse? Loss of control, that is, they can't control what they're taking. They're continue to use the drug because despite harm, and these ruminating thoughts which tend to surround the drug itself. I would just, those last three bullets on the right side there, it's just a good yardstick for measuring other aspects of addiction that might be in the patient's life. Certainly, we're talking here primarily about controlled substances, but people can have any sort of addiction that can really interfere with their life, whether it be gambling or sex addiction or a work addiction. I mean, there's all sorts of things that we can identify in ourselves and other people where there's loss of control, use despite that hurting somebody, continued behaviors that are harmful that people can't seem to break away from, and perseverations on these sorts of things. So it's just when we talk about addiction, it's important to remember that particular part. So how do we measure pain? Well, we all understand that it's, again, it's subjective, right? And so that can become very, very difficult. We rely upon and use the numerical rating scale, the NRS. I'll get back to that in a second. For those that don't have the capacity of communicating, we use a visual analog scale. There's one that's called the Defense and Veterans Pain Rating Scale, Adult Nonverbal Pain Scale. There's the Pain Assessment Advanced Dementia Scale, or the PAIN-AD, a Behavioral Pain Scale, Critical Care Observation Tool. There are more. There's no shortage of these tools that help us, that are supposedly help us to identify the level of someone's pain. And I'm somewhat of a skeptic, simply because it's a number that the patient is able to use, but how reliable is it? There's the 1 to 10 pain scales. There's the FACES scale that we use in pediatrics a lot, Global Pain Scale, Visual Analog Pain Scale, McGill Pain Scale, Mankowski Pain Scale, the color scales for pain, and there are other pediatric pain scales. So you start to see that which ones to use when and how effective are they. Well, let's just talk about the numerical pain scale, because that is what was embedded into our care systems in the hospitals about 40 years ago. It was in the 1980s that you started to see the pain as the 6th vital sign. And in general, 1 to 4, and really it's exactly what you think it is. On a scale of 0 to 10 being 0, no pain, and 10 being the most severe pain you can imagine, where's your pain today, right now? And mild is 1 to 4, moderate 5 to 6, severe 7 to 10 is the general approach to that. And if they're up in the upper echelon 9, 10, that's probably pain crisis. People use different language. No, I don't have any pain, but I'm uncomfortable. Okay, we'll use your terminology. Is it tolerable or intolerable? Is it continuous, episodic, incidental? Again, those are very, very important to understand. If you understand what their disease is, what would we expect? Would they have continuous pain? If untreated and someone has metastatic disease to their bone from their from the colon cancer, I would expect continuous pain. And again, we want to make sure that we are doing everything we can to prevent the pain and be proactive and preemptive about it. Episodic pain, very common in cancer, where it just pops out of nowhere. You just, that breakthrough pain, that sometimes that terminology is used, and we don't know when it's going to occur. And so we want to make sure our baseline pain is treated as best as possible to limit the number and extent of episodes that they would have that breakthrough pain. And then incidental pain, and it's sort of exactly what it says. It's incident to some sort of injury or some sort of behavior. So when you do this, it hurts. Of course, the old anecdote is that, well, then stop doing that. But sometimes it's unavoidable. The elderly who are being moved for dressing changes or for care within the nursing home may have significant pain when we're doing that. That's incidental pain. If it's just incidental pain, how do we manage that, again, proactively so that we can minimize the discomfort that they have? I mentioned earlier about the functional impact of pain. Let me just go to the next slide because this really kind of addresses that better. The way that I tend to deal with this sometimes, I usually will ask about a number because that's what the patients expect, and a lot of times they're thinking about that. But when I make my therapeutic decisions, it's usually based on these couple of questions. 1 to 10 is not always reliable, right? There are patients who are always a 7, no matter what you do, or they're always a 3 or 4 because they don't want us to think that they're somehow gaming the system or that they're drug seeking, and so so giving us a falsely low number. I have found the scale to be useful in assessing the progression of disease or the impact of our intervention. If they were an 8 and we gave them something and 4 hours later they're a 4, well, we're on the right track, right? So I think that it does well for for assessing progress. I think that my 7 for me may be different than your 7. It might be different than a patient's 7. So that's where it becomes difficult. But this next question is always central to my pain evaluation. What are you not able to do because of your pain? And it's important to remember to ask that question, because that's going to help to sort out. If I've got someone who is complaining of a high level, but they're still going to work every day and their work is somewhat physical, are they just stoic, a martyr? What's going on that causes them to be able to manage normal function out, mowing the grass and doing other sorts of things, and yet still complain of a high level of pain? I was asked to see a young lady in the hospital for chronic abdominal pelvic pain. She was 27 years old, and this was not her first time in the hospital for pain. In fact, she had been in multiple times over the previous 3-4 years with these complaints of severe pain, and it was the same routine every time. She would come in, get her IV dilaudid, would have some sort of studies done, blood work. By the way, blood work rarely is going to tell you why they're having pain. You might get a hypercalcemia now and then, but for the most part, blood work is not going to be the answer. She was scanned from head to toe, and of course the abdominal and pelvic CTs, ultrasounds, MRI included, showed nothing. She'd had a laparoscopy, which showed nothing. And so when I came into the room, one of the things that I always think about with that type of a story in a young woman is there's some element of abuse in her past that could be contributing to her pain. Remember, we talked at the beginning about how important cortical implications of pain are. She told me when I walked in the room, she was standing up by the bedside table across the room from the bed. And when I walked in, she turned around, had this bright smile on her face, and I said, "Hi, I'm Dr. Mulder, here to help you with your pain." And she literally, "Oh, great, this is wonderful because I'm really, really hurting, and I'm glad you're here to help me." And jumped into bed and pulled her blanket up and then looked at me, cute little smile. And I said, "How's your pain today?" She says, "Oh, it's a 9. And in one of the very, very few times that I've ever told a patient this, I said, "I'm not sure I believe that it's a 9. And she looked indignant and at me, and she said, "What, you don't believe me? Would you believe me if I were screaming and crying and writhing?" Which she then flipped a switch and showed me that face, showed me that characteristic of just being in agony. And then she stopped and said, "So if I did that, then you'd believe me?" And I said, "Well, actually, I would. The fact that you can switch it on and off like that suggests that it's not really a 9. I said, let's be really clear. I understand that you're hurting. I understand that it's disabling for you. I understand that you've got some issues. But I think we need to look at some different strategies for managing your pain, because what you're doing now, these repetitive trips to the ER and hospitalizations and such, they really haven't addressed it, have they? It really has not gotten you on top of your pain. And here you are back in the hospital again. Well, if I just get my Dilaudid, then I'll be fine. Now, my approach to her was not that she's just a drug seeker, I'm going to just dismiss her, was that there must be some psychospiritual underlying issue to her pain that needs to be explored. I'm not the first one that was trying to do that, work that process with her. And in fact, she was not happy with that particular line of questioning and inquisition, and she fired me within an hour. But I think that we need to be careful about understanding what someone's functional capacity is as a result of their pain, and that's going to help to guide us. With the first bullet on there, are you comfortable with your current pain control? Regardless of the number, if they're not comfortable, then I'm going to be dealing with that. We need to address that. If they are comfortable with their level of pain control, then regardless of what the number is, I don't think I really need to do much else. If you're comfortable, you're able to do all the things you want to do, your life is not limited because of pain, then the number becomes less relevant. Hope all that makes sense. Now, all that being said, we have a tendency to focus on the pharmacologic treatment of pain. It's what we have a tendency to do, and that's how we have often been trained. We write a prescription for them. And frankly, for most of the patients that I see that have pain, that's going to be part of their regimen. So I wanted to just walk through a few basic steps. Again, hopefully most of this will be second nature to you. And we've only got a couple minutes left anyway. I might pick this up next week. In fact, I'm looking at the clock. I will pick this up. We'll start talking about pharmacologic treatment of pain next week. So I'm going to stop sharing here and just see, does anyone have any questions, thoughts, or comments about what we've talked about so far this morning? Well, hearing none, it must be crystal clear, huh? Okay. We'll talk more about it. If one thing that I have always asked students when I'm doing multiple lectures on pain for the medical students is that keep track of the types of things that pop up in the course of your day and week over the next few days. And just jot it down. When we meet next week, we'll have a few minutes so we can talk about some of the concerns, issues, curiosities you have about pain, so we can address those also. And yes, Gretchen, thanks for echoing the warm welcome to all of our new fellows. And I just wanted to note that we have a new fellowship program also that is joining us. I see Dr. James Fletcher's on the call here today. Sparrow has a brand new fellowship program. So James, welcome to our very friendly and engaging cadre of folks here.
Well, thank you for inviting us. I think we're just so happy that to join your consortium.
Yeah, and I see people are starting to drop off. So next week. We'll do some, for the fellows, I'm going to call on you next week just to show your face and give us a little introduction so everybody's aware of the new fellows. We'll do that next week. So, all right. Well, thank you all for your time and attention, and have a wonderful rest of your day and a good week. And again, there's no case presentation today. So I'm just going to go ahead and disconnect this call, and we'll look forward to seeing you all next week.
Right.